Good evening and welcome to the fourth of our journal clubs for the European Journal of Hand Surgery. I'm delighted to be here with you. My name is Zaf Naqui and I am chairing tonight's session on behalf of the Digital Committee of the Journal of Hand Surgery. We've got a special edition tonight where we're focusing on an issue put together by Lam, the handling editor, on dogmas in hand surgery, and I'm delighted to have our special panel with us. So I'd like to introduce them before we go any further. We have Dr. Marybeth Ezaki from the Scottish Rite Hospital, Texas, and an ex-president of the American Society for Surgery of the Hand. We have with us our second author is Professor Tim Davis from Nottingham. And then our panel of experts, we have Gill Smith from Great Ormond Street in London, and Professor Sir Stephen Hovius from the Erasmus University of Rotterdam. Our presenters, so the handling editor is Lam, as I've mentioned, and our presenters tonight, we have Andreea Lupu, who's a post-CCT hand fellow in Leeds, and Inga Besmens, who is a consultant in Zurich and ex-president of the Young European Hand Surgeon Society. So I'm going to kick off the proceedings by inviting Inga to give the first presentation, which will be on the congenital hand paper by Dr. Ezaki. And then we will open up the discussions following that. So Inga, would you be kind enough to kick things off for us?
Thank you so much, Zaf. Thank you for having me. My name is Inga Besmens, and I'm the current YEHS Vice President. An issue close to my heart, I want to let you know all about YEHS. We are the Young European Hand Surgeons, the young group of the FASH. But let's focus on tonight, because tonight I will be presenting a paper by Marybeth Ezaki called Challenging the Dogma, a straight wrist should be the goal in radial dysplasia. Let me start by giving you a short overview of the article. Many techniques have been described to stabilize the carpus on the forearm in radial dysplasia, assuming this would be better for function and aesthetics. Ulnocarpal fusion techniques have been the only ones successful in preventing recurrence of radial deviation. Ulnocarpal fusion, however, carries the risk of shortening an already shortened forearm by damaging the epiphysis. As in these patients, fingers are often extremely stiff. A straight wrist might actually limit function. The assessment of appearance throughout the literature remains inconclusive, and taking these factors into consideration, the optimal management remains debatable. Therefore, the author challenges the dogma that a straight wrist should be the goal in radial dysplasia treatment. Please note that in this article, radial dysplasia refers to type 3 and 4 according to Bain and Klug, as you can see here on the right-hand side. The article is not a systematic review, but instead it focuses on other articles relevant to the dogma that a straight wrist is the goal for patients with radial dysplasia. The historical assumption is that a straight upper limb means more normality. It supposedly gives a mechanical advantage and more strength. Also, it is supposed to increase the reach and functional range of the sensate hand. But it is important to note that in these patients, function is reliant on digital mobility, and in radial dysplasia, oftentimes, fingers are stiff. The author looks at different articles focused on different treatment techniques. Let me walk you through these articles the author is quoting. First, she takes a closer look at articles concerning centralization and radialization procedures. A study published by Heikel found that it's difficult to predict results of treatment and to judge whether the patient will actually benefit from surgical intervention. Function of the fingers is not changed by correction of the wrist, and if that's the case, one can argue that the function of the limb is actually lessened by further loss of mobility of the wrist, as it is uncompensated by any improvement in finger motion. Ankylosis between the ulnar carpus or metacarpus is justified only from a cosmetic or psychological standpoint, while it is to be condemned from a functional point of view. Frankel et al. Posed the question if radialization, or in this case, centralization, as the title goes, was really necessary. They had a study size of 32 patients and found that fixed centralization produced limited function in bilateral cases, but could be justified in unilateral cases. Frankel's team, however, abandoned centralization in favor of soft tissue release and splitting. Ben and Klug published a long-term review of the surgical treatment of radial deficiency. They saw good or satisfactory results, which were defined by maintenance of motion or growth without deformity recurrence. However, they also noted that patients treated elsewhere did not have the same results as they did. And it has to be pointed out that at their department, treatment was always combined with prolonged splitting regimes. Moore et al. Assessed radiographic measurements in the follow-up of radial dysplasia treatments of infants. They saw the deformity recurred with an average preoperative angulation of 83 degrees, improving to 25 degrees immediately postoperatively, and at final follow-up back to 63 degrees, which translates into a loss of a correction of 38 degrees at final follow-up. Goldfarb et al. Looked at the functional outcome 20 years post-centralization procedures. They found improved wrist alignment and increased ulnar length did not correlate with improved upper extremity function. Patients had minimal pain, but were dissatisfied with the limb appearance. There was a lack of correlation between dash scores and forearm length or wrist position. Functional impairment was caused by a limitation in a finger and thumb function and not by more proximal manifestations. Steroid et al. Looked at the growth pattern in radial longitudinal deficiency in a study size of 124 limbs in 90 patients. They found that ulnar notching led to less recurrence of the deformity, but also less growth, meaning a shorter and actually stiffer limb. Non-notch centralization had a greater risk of recurrence of wrist deviation. The group concluded that a balance must be found between desired growth and risk of recurrence. Codwell et al. Performed a comparison of 309 wrists with notch centralization with 137 wrists on patients who were not operated on. They found that non-surgically treated patients rely on adaptive movement for function. Surgically treated patients had better position of the limb, better percentage of normal grip strength, and satisfaction with aesthetic appearance. But the operated group had a 45% complication rate, including reoperation, recurrence of ulnar bow, and loss of correction. So the next treatment option the author is looking at is soft tissue distraction before centralization. Dana et al. Published on the recurrence of radial bowing after soft tissue distraction and subsequent realization for radial longitudinal deficiency. The study was comprised of 8 patients, and they saw a recurrence of radial bowing in 7 of these 8 patients, then thus concluded that soft tissue balancing plus radialization is not effective in maintaining correction. Manske et al. Looked at the effect of soft tissue distraction on deformity recurrence after centralization. They treated 13 wrists with distraction and 13 without. They found that prior distraction facilitated centralization, but it did not prevent deformity recurrence and was associated with an actual worse of finer radial deviation and a volosubluxation position compared with the wrist treated with centralization alone. Now, this study here reports on the long-term results on recurrence rate of radial deviation following centralization. An acceptable long-term result is expected after centralization. However, the risk of recurrent radial deviation was considered to be high. Next, the author focuses on papers on radial substitution procedures. De Jong et al. Published 12 cases of microvascular joint transfer for correction of radial deviation and preservation of long-term growth. This technique was originally described by the senior author in 1992. 24 cases were subsequently performed with an average of 11-year follow-up. The authors noted that they find this to be a promising but very demanding technique. Innocenti et al. Report on the movement of the proximal fibula with its physics for distal radius reconstruction in children after tumor excision. This led to only minimal discrepancy between the final length of the new radius and the existing ulna. It's important, however, to note that this is a technique used in a different patient clientele and might not be appropriate in radial longitudinal deficiency. To give you a short summary, Fixed centralization will typically limit wrist function. It is justified primarily for aesthetic reasons in a unilateral setting. Prior distraction facilitates centralization, but it comes with a higher rate of deformity recurrence. Radial substitution procedures could potentially be promising, and keeping these factors in mind, the author concludes by giving us her department's approach to the complex problem of radial dysplasia treatment. Centralization and radialization procedures have been abandoned in her department after unsatisfactory results. Instead, the team focuses on tissue release and bilobed flap coverage of the deficient radial side to improve the resting angle, while at the same time preserving active motion of the wrist. At a mean of 9 years follow-up, patients had a resting angle of 64 degrees with 88 degrees preoperatively. Average active wrist flexion extension arc was 73 degrees. The average DASH score, as you can see, was 27, and the YEHS for appearance was very good, it was 1.2. So we could conclude that equal or more emphasis need to be given to a psychosocial support of the child in accepting an upper limb that may look abnormal but function perfectly well. I enjoyed reading this paper very much. I think it gives a true expert opinion on a very complex topic. It gives a very good synopsis of the literature available and focuses on the relevant treatment techniques. Naturally, the study sizes in a rare condition are rather small, and there is a slight risk of bias, as this is not a systematic review, but focuses on articles handpicked by the author. Thank you so much.
Thank you, Inga, for that presentation. Before I go to the expert panel, I'd like to invite Dr. Ezaki just to give us a few words really on how she went about writing this paper and just her thought process when she was requested to put in for this paper. Dr. Ezaki?
Thank you, Zaf. This is one of the most complicated and one of the most humbling procedures and well, diagnosis and procedures that we face in taking care of the children with congenital upper limb problems. I think there is a great deal of social pressure and psychological anguish that comes along with the parents as they present with the child with this particular condition, or any condition, but particularly this condition. Many of the families will think, well, the cardiothoracic surgeons fixed my baby's heart and they were out of the hospital in a couple of days and everything is fine. And this is just an upper limb, you can fix it, of course. But early on in my career, I read the books and I did centralizations, and they all recurred. Some of them more rapidly than others, but they all recurred. I was at a referral hospital and I saw many patients who came in who had had their surgery elsewhere, either referred by the doctor who had done the surgery, or patients that were coming for a second opinion in which their surgeons had no idea they were coming back in, or they were coming to me. And so it made me feel a little bit better that I wasn't the worst surgeon in the world, that I was having the same kind of complications that other people were having. Tried the different techniques, tried radialization, then went on to some soft tissue distraction before doing the centralizations, and I still was faced with the problem that I wasn't satisfied. I referred to something in the paper that's called the sunk cost fallacy, that if you put a whole lot of effort into doing something, that you have already bought into this, and the parents have bought into this, and they don't want to admit defeat. Some wonderful literature on that issue. And so when we asked me to tackle this particular controversy, it was something that I felt passionately about. I don't think I'm a bad surgeon, but this is an operation that I just couldn't make it work. And I wasn't satisfied with the results or accepting the results, and also thinking that if you sat down with a patient and you told them that you wanted to operate on their baby and there was going to be probably a 50% complication rate, and there were going to be scars and you were going to quote unquote burn bridges, I think as an informed parent, or a grandparent now, I would question the wisdom in being advised to do that operation. So our unit came around to doing something which we thought would not burn bridges, would do something for the parents to improve the condition of the child. And we could go on to do something later on. And so discuss that a little bit in the paper too. So anyway, that's how I came to my decisions on how to treat these kids. Yep.
Thank you, Marybeth. So I'll go to Gill first. Gill, Dr. Ezaki makes a very convincing argument in her paper. So I imagine that you're in agreement here in terms of the arguments put across.
Well, firstly, may I say I have a great deal of respect for Marybeth Ezaki. And you know when somebody says that, they're about to disagree with them. Marybeth Ezaki has taught me an awful lot. She's more senior than I, and I have a great deal of respect for her. But it doesn't mean I always have to agree with her. So I would agree with some things. Why do we normally want a straight wrist? Well, we want it for mechanical strength and advantage. We want to increase reach. We want a functional range, which is good. And a straight wrist in normal circumstances allows normal muscles to work at an optimum length of stretch for efficiency, whereas a flex one, you lose efficiency of grip. And we all know that in normal activities. It also looks a little bit more natural. It isn't so socially stigmatizing and allows better social function and participation. We might not always want it in radial dysplasia because all radial dysplasia cases are not created equally. Some have pretty mobile fingers, and a stable wrist in those may help. Some have a terrible shoulder and they have stiff fingers, and in those they lose all ability to pronate and supinate through their wrist and their shoulders not compensating, so they may not benefit. But none of us operate on all of the patients that come with radial dysplasia. So the threshold for surgery is going to differ. All of these patients are going to be able to compensate well, a little bit differently according to how good their anatomy is, but it's not going to be comparable to levels of disability as described in adults and detailed in a desktop exercise, completely different. And I would agree that straight wrist is not necessarily a functional benefit in those with stiff fingers. But for those with more mobile fingers, function is broader than just limited to movement and ability to use. It's much more to do with whether they participate. And we actually neglect what the parents and also later what the patients want. And actually, we don't really know what the patients want because all of us want normal fingers with a normal length forearm, with normal pronation and supination and normal wrist motion, but you can't always have that. Radial longitudinal dysplasia is where surgeons want to play God. And in type 3 and 4, there is no relationship with the radius in the first place. And we're trying to balance the end of the hand on the end of the forearm without normal muscles and without any bony structural support. And we either do it by balancing it on the ulnar and hoping it will stay there, or by importing additional bone, readjusting the soft tissues and then hoping it will stay there, even though the child's just about to start growing and act as a moving target. So I actually welcome this paper. I think it's an excellent idea. It challenges dogma, but I don't agree with it all. I agree recurrence is common, and I agree that we haven't got the right answer yet. And in most joints, an increased range of motion also means an increased range of instability, which is why procedures that allow more motion in the wrist after trying to rebalance do have a higher risk of recurrent deviation. And the stiffer it is afterwards, the more likely it's not going to fall off its perch. But I disagree about growth because since we've used soft tissue distraction, the growth that we get is pretty much what we expect, which if you do nothing is about 60% of normal. However, the best long-term results, without a doubt, are shown in that paper by Cotwell et al. 309 patients operated on compared to 137 that weren't. And the operated had better position of the limb, better grip strength, better aesthetics. Only 10% actually had recurrence that required reposition of the hand forearm angle, and there were 31% that had an ulnar osteotomy for an ulnar bow. In fact, the mean hand forearm angle was 85 in the non-operated compared to 12 in the operated. The Poofy score was better. Other authors, such as Geck, have shown that you get a survivorship of 67% of less than 14 degrees radial deviation at 5 years, which is actually pretty good. I think that's not bad at all. All surgeons, however, are not created equal. And unfortunately, the way the operations are described in the literature is not only in small series, but often different operations are described as the same thing, or they're not described at all well, or they're only followed up for a short time. And the series by Mansky, for instance, that's quoted, saying that they do much worse if you have radialization, actually had a very different amount of soft tissue dissection between the radialization and the centralization.
Okay.
So all of us have seen children with a childhood destroyed by recurrent procedures. And this is where the motivation to reduce complexity and release only the soft tissues has come from.
Okay.
Research shows that even down to a molecular level, the soft tissues are abnormal in this condition, and Wolff's law necessitates that these will affect the shape of the bone. So in this respect, the idea of releasing the abnormal soft tissues is reasonable. But I consider this operation that Marybeth has suggested is a sham operation to appease the parents. What we really need to know is which patients do badly with conventional procedures, as it's difficult to predict. And whatever operations needed, we need to address both the bone and soft tissue as both are abnormal. So why do we use this position as a way of evaluating radial club hand? Probably because it is something we can correct, whereas all the other problems we can't. So I want to ask Marybeth, how do you balance and justify the results of Cotnell with your opinion of soft tissue release alone? And why does your soft tissue release alone not just refibrose with scar when the K-wire is removed?
I'll let Marybeth ask that before we move on to Stephen.
The soft tissue releases that we're doing allows us to resurface the concavity of on the radial side of the wrist. And so there's an aesthetic improvement. The soft tissue releases are really to remove the radial deviating forces, and those don't tend to scar back down because we use some splinting afterwards. And again, the idea is that you still have the option, if we wanted later on, to do a centralization procedure or a radialization procedure or Wilke's procedure, and do it at a time when there has been additional growth to the distal ulna. So I don't think it really burns those bridges.
Can I bring in Stephen? Stephen, please, your thoughts on this paper.
Bring it on, Stephen.
Hi, Marybeth, and thank you, Zaf, for inviting me for this meeting. I love people who go against the normal line of thinking, because they make us think, and that is one thing Marybeth and also Tim does very well, and that's very good, because it made me look again at all our figures and figures of the literature, as also mentioned by Marybeth. And I had the same as Gill had. The Cotwell series are quite convincing because they're very large. And unfortunately, Marybeth has only 18 wrists and 16 patients, which she covers. I think a few things, and then I'll stop because Gill has said a lot. And most of the things Gill has said, I agree upon, is that maybe a few other things. Ekblom in Sweden has looked at the function and has stated that finger motion and strength are not influenced by the position of the wrist, as Marybeth has also said, but there are other things, forearm length and elbow motion. Well, first of all, we never operate on patients who have stiff elbows. So that point you can sort of rule out. Then there's the question of the forearm length. Well, first of all, Marybeth, we have shown that 75% of the normal arm length of the children in their age group has been preserved if you do a distraction and take it for a long while. If you do not do distraction, do centralization, which means basically a wrist arthrodesis, then you will lose a lot, even up to 63%, which is huge if you compare to non-operated patients who have only 35% impaired growth. So I think growth is a very important issue in this. And yes, you do get recurrence after distraction. Long term, at 6 years long term, we looked at it in comparing groups with and without distraction, and you have the same results in terms of angulation. Yes, it comes back, but it's much more easy to do it there. Should you do it, yes or no? Well, I'm not convinced by just releasing soft structures. Only 20 degrees difference doesn't really make a difference to me. And but I do think, and that's what Gill has emphasized, we should not operate on very stiff-fingered patients with a very stiff bowing, etc., etc. I think that's wrong. The same, I will never do a policization in an elder-sided hand grip in real dysplasia. That's the same thing. It's the same token as you were saying by the wrist. And I know people are doing policizations. Our group of patients where we did policization have bad grip strength, and so I'm very cautious about doing policizations in these children. So I think I've said enough. Basically, I can go on and on, but I will not.
Before we move on, there's a couple of questions from the delegates who've joined us. Professor Grania-Burke asks the panel what they think of the role of enlarged excision in delivering mobility and growth. And Anuj Mishra from Manchester is also asking for views on the role of telescopic rods in management. Does any of the panel want to take on either of those? In fact, I think we go back to Marybeth actually to start with, and then Marybeth, if you wanted to respond either to Steve or those questions.
Well, I have no experience with any kind of a telescopic rod in this condition. And for the quote unquote, the enlarged excision, usually we talk about that in ulnar dysplastic limbs. Sometimes there is a very thick fibrous tether on the radial side that extends from whatever soft tissue there is, and that's part of the soft tissue release that we do. So I guess if you're going to call that an enlarged, then I have excised some of those.
Okay, thank you. We are pressed for time, so I'm going to bring in before we move on to the next topic. First of all, I wanted to ask you really about this edition as one of the editors of the journal. You've gone for essentially opinion pieces here with what you've done with that with the issue. Why did you come up with this concept, and how did you go about picking your experts and the topics?
So the idea came about when I had a discussion with Jimbo Tang, the editor-in-chief, where he was telling me his dissatisfaction with how everybody was calling the Edinburgh position without the position of safe immobilization, without really challenging it. And then we came up with the idea of a special issue in challenging dogmas. It has been a very interesting issue to edit, because everyone that we invite to write this article, as you can see tonight, there will be lots of controversies, lots of discussions. It's not going to be an easy job for the author. But it was a very interesting issue to look at the different areas of dogmas, to define what a dogma is, because a dogma to one person may not be a dogma to another. A dogma in one country is not a dogma to another. And I know what I'm putting the authors through, but look at the amount of discussion is generated. So we then decided that we would choose topics that we perhaps feel some discomfort at the moment about the fact that these areas have been unchallenged for decades, or maybe an eponymous name which has just been there for too long. We decided to pick these topics. We decided to pick topics across the entire range of hand surgery, congenital, nerve, wrist, cover as much grounds as possible. And that's how we settled on the final list of topics.
And how do you go about your editorial process when the experts that you've chosen yourself come back to you with their articles? How do you then pick them back with doing due process as the editor? So
as I said, I mean, we give them very clear instructions. You are to define the dogma. You are to be very honest even if you feel your own practice is dogma, and be prepared that others will question you and challenge you to examine your current evidence, to examine the current evidence, and finally give your personal opinion. And we know the final article may not be one that everybody agrees with, but we think it will be one that a lot of people will want to read. And most importantly, it will stimulate critical thinking. That's the most important thing. It is not to present a new article as another dogma. It is to stimulate critical thinking.
So that leads us nicely on really to our next topic, in terms of whether we are challenging dogma or actually reaffirming dogma. Now I'm going to invite Andreea Lupu to present Professor Tim Davis's paper, and then we will re-engage with discussions after that. So, Andreea.
Hi, good evening. I'm Andreea Lupu, and I'm a Hans Fellow at Leeds General Infirmary. And if you look just behind my shoulder, you can actually see the hospital just in the background. So I'd like to present Professor Davis's paper, where he gives us his personal approach of the treatment of trapeziometacarpal joint arthritis. So there seems to be a bit of controversy, and there are dogmas around the treatment of thumb-based arthritis. And Professor Davis will challenge these and offer his expert opinion using a stepwise approach. What are these dogmas? Well, what actually causes this condition to become painful and symptomatic? We don't really know still. When should we offer a patient surgery? And what should that surgery be? So there's evidence to show that X-ray findings don't necessarily correlate with clinical symptoms. In '94, Armstrong and the team looked at the risks of 143 postmenopausal women and found 25% of them had coincidental thumb-based OA. And the majority of these women actually didn't have any symptoms. 75% had no symptoms. So there must be something else going on that's leading to these clinical symptoms. Maybe other physical factors, but definitely psychological factors should not be overlooked. And maybe if we can identify these psychological factors and address them, we might open up new treatment plans that could improve non-operative management, but also could improve our surgical outcomes. How long should we wait before surgery is offered? There's often a misconception that once the patient reaches an extreme level of pain, that's it. It's going to go downhill and they have to have surgery. But maybe that isn't the case. Maybe we could give it more time for the patient to see, are things going to get better? Or can they actually manage this pain without surgery? Can they incorporate that as part of their normal function in life? And also, it gives them a bit of time to just consider that it's okay to have some pain before rushing to opt for surgery. So the author recommends waiting between 3 and 6 months from the onset of intolerable pain. What about non-operative options? Well, Gravas et al. Showed that occupational therapy doesn't actually reduce the rate of surgery, nor does it delay surgery. But we find that splints can be beneficial for patients. I'm not sure why, but maybe a reason would be that they stop the joint from moving, so hence it's no longer painful. Steroid and hyaluronidase injections have been looked at, and Ezaki and Riley actually found that there is no significant difference between these injections and saline into or around the TMC joint. But for some patients, steroid injections are very valuable. So we should also consider this old-fashioned idea of 3 is the maximum amount of injections you have, because there isn't evidence for that. So if a patient finds that a steroid injection is beneficial, then maybe they can carry on having this every 6 months until they decide that that is no longer an option for them. And that's what Professor Davis would recommend. Another interesting and helpful reminder is that it is actually the patient who should decide when their pain is bad enough and not the surgeon. because the way we present the benefits and risks of surgery, how enthusiastic we are about operating, how negative we are, all this really affects the patient's decision-making. And another important reminder is that delaying treatment does no harm. And that may reassure the patient that they don't have to rush into a decision. It may calm their anxieties around decision-making. But also, the author finds that the more severe the condition is perceived by the patient in terms of their functional deficit and pain severity, the better an outcome they'll have from surgery, most probably. And then another point is made about the functional or psychological issues. So issues such as depression and anxiety should be studied further and should be addressed and managed, because maybe in doing so, we might be more successful in helping these patients cope with their arthritis and maybe even reduce the need for surgery. What about the options for surgery? Well, trapeziectomy alone is a classical choice, and Professor Davis has published widely on this topic, and that seems to be his favorite option. Trapeziectomy and ligament reconstruction, however, hasn't been proven to be superior to trapeziectomy alone. However, there may be a place for it in the author's practice in maybe about 10% of his patients, where they're younger, more active, and possibly more demanding, and when the author thinks they may question their decision-making. Implant arthroplasty has been around for some time, but we still are lacking robust long-term results. That's over 10 years. And Professor Davis is welcoming a compulsory registry for TMC joint arthroplasties, and also a randomized control trial comparing trapeziectomy and implant arthroplasty. This is a lovely summary that's given to us of how to approach a patient with thumb-based arthritis. In the initial consultation, there's a lot of time spent on understanding the patient's level of pain, level of loss of function, and generally how this thumb-based arthritis is impacting on their daily life and quality of life. There's time spent educating the patient on what the disease is and what their options are. And again, emphasis is placed on not rushing to make a decision about surgery. And they get an immediate steroid injection in clinic if it's found suitable. Between 6 to 12 weeks later, they're followed up, and either they get discharged or they have further injections, or they get listed for surgery. And the operation would be a simple trapeziectomy, no K-wires, and they would stay in a cast post-operatively for 4 weeks, after which the patient does their own range of movement exercises. We are given some ideas for further research projects, and we could be looking at outcomes of non-operative, painful thumb-based OA, and also looking more closely into what actually leads to these symptoms, particularly the psychological factors, identifying them and managing them. We could also look to standardize both the indications for surgery and also standardize non-operative treatment. And this is my personal favorite, is a call for an adequately funded and compulsory hand and wrist registry. That's either international or national. So overall, I found this to be a very practical and useful evidence-based guide. Although it is an expert opinion in terms of levels of evidence, I think it's based on robust research. It identifies areas that do need further research, so it gives some ideas and some food for thought. And for me, it's changed my practice that I will spend more time in history taking and understanding the levels of pain. And I'll be more confident to offer a steroid injection in clinic. And a good reminder that time is a friend. Thank you.
Thank you very much, Andreea. Fantastic. It takes us nicely to a discussion. I'm actually going to start by asking Professor Davis. The paper is called, it's given your opinion, so I think that's fine in terms of the title of the paper. The edition, so it may be a question for both yourself and we, the edition is Challenging Surgical Dogma in Hand Surgery, and maybe members of the British audience would feel, and in fact that we have had a question from one of our viewers, is did you feel that you were challenging dogma in that paper, Tim, or were you representing what we would consider the dogma, which is trapeziectomy alone is the way to manage CMCJ arthritis?
I wasn't just looking at trapeziectomy alone. I mean, dogma, as far as I can see, are opinions which have virtually no basis if you look for evidence to support them, or weak evidence. And what I've done in this paper was I didn't really want to concentrate on the personal approach, that's the way it ended up, but was highlight areas where I think there is controversy, we don't know what works and what doesn't, and say these are areas which need research to try and get rid of dogma and sort it out. And I think a lot of non-operative treatments and implants, there's an awful lot of dogma around, but do we really know what works and how well they work? And if you don't study them carefully and scientifically, you'll just carry on with more and more dogma. So okay. This was a dogma eradication. That was my aim of it, because everybody has different dogmas. They're all around, and the only way you'll try and smooth them out, and even that even work is by careful study in a critical way. And I'll be the first to admit that my trapeziectomy studies wouldn't stand criticism from modern trial mythologists, because though they're randomized and controlled, they're quite open to bias and things like that. But the only way forward to get rid of dogma, in my view, is to have a better evidence base of better quality.
Thank you, Prof. So let me go over to Steve. Stephen, you very thorough paper there by Tim, going through various aspects of CMCJ arthritis. I guess you're on the same page as Prof. Davis, therefore, in terms of how he's addressed this issue and his thought process.
Well, thank you, Zaf, again, and thank you, Tim, for putting this forward. I have two things to support and a few things to have a non-support, if you like, or to counter. First of all, I like the fact that less is more, which if you have in surgery, you've proven that in 2 RCTs, especially also at the 5 years, that the trapeziectomy alone has less complications, is just as good. And we have in 806 patients having different techniques, that the lesser technique, which is only doing a palmaris longus graft or something like that into the space, which is not enough covering it, by the way, has the most beneficial one after 1 year in terms of less complications and the same kind of outcome, using MHQ as an outcome. The MHQ is a Michigan Hand Questionnaire. If you go to table 1 of Tim, I support him for most of the stuff, but he's also saying there's not evidence out there in terms of conservative management. And I would like to counter him on that. We have done 2 large studies and a systematic review on conservative management. And I would like to point out that the study we've done was after 14 days and after 3 to 5 days starting movement already. So the 4 weeks or 6 weeks, even if a lot of people do, is not necessary, because we didn't find after 1 year any difference between these 2 groups in pain and in function. So that's 1. 2, if you look at our series, and that was of 812 patients with a 1-year follow-up, then we've seen that only 15% of the conservative management, meaning hand therapy and splinting, of course there are differences inside that. People don't wear splints and don't come to hand therapy, or come to hand therapy or wear their splints all the time. I know that, but the end of the story was that of these 812 patients, only 15%, 1/5, went on to surgery. That means that 85% in our small country do well, and by purely giving them conservative treatment. So there is evidence out there, both published papers, by the way, one in 2017, one in 2019, and another one in 2019. Then I would like to close that particular, oh, by the way, after 6 weeks, we could not get them very much better of conservative therapy, but we made a sort of block at 3 months and then followed them again to a year. And interestingly enough, from 6 weeks to 3 months, the conservative treatment didn't improve very much more. So the first 6 weeks are very important. And then on shared decision making, MHQ is good for us because it gives you pain and function scores, and you can tell your patient, listen, you have a lot of pain, but your function is quite nice. So let's talk about the pain improvement we can give you. Or the other way around, if you have a not so much pain and a rather good function, should you operate? I mean, why should we? And please go on to conservative management. In that case, I would support Tim. The last point I would like to make is some psychological effects. We have looked at, let me see, how much was that? Something like a couple of hundred, I'm not sure again, I can't see it in my notes. David Ring has looked at it also, I think. But anyway, we have published that in 2019, and we saw that at baseline, the pain was, the variance of pain was in 42% psychological factors, and only a few percent on socio-demographics, and only a few percent on the severeness of the osteoarthritis. So 42% on illness perception, on pain catastrophizing, and on anxiety. But it leaves us with another 50%, which is unexplained. So why is that 50% unexplained? We cannot explain it yet. These are my comments. Thank you.
Thank you, Steve. Tim, would you like to come back, counter on any of those? You're muted.
Sorry, I was just calming down. With it, no, I generally agree with Steve there. I mean, the thing is, non-operative treatment does work. I mean, but the question is which types work. I mean, at the moment in the UK, there's a trend for health authorities to put out guidelines of things you have to do to patients, say with carpal tunnel or trigger finger, before you can consider surgery. And I get the feeling that patients are sort of being sent around a circle of trying a splint, well, certainly splintage for trigger fingers and other things, not even necessarily having a steroid injection till they've been through splints and other things, which I know very little evidence works, before actually getting a treatment which works. So I think it's important to differentiate between non-operative treatments, what really has a benefit and what does not. And with all the non-operative treatments you were talking about, Stephen, and do correct me if I'm wrong, there was an awful lot of talking to patients and discussing with them. And you see, I just wonder if that is equally as good sometimes as a splint or as anything else. I mean, I see an awful lot of patients in clinic and I tell them what I think about the operation. It works 8 times out of 10. It's a last resort. You can have it whenever you want. So going away now and coming back later does no harm. It can still be done. And then I discharge them or give them an open appointment for 3 months so they can come back. And if they don't come back in that time, they have to go through. And like you, a large majority never return. And then some start appearing later on, 6 years or 10 years. But I'm sure the vast majority never come back. And I think just knowing there is a bailout, if it ever gets too bad, it will never be too bad to do the bailout. I think that is a very strong non-operative treatment. So I think in a way we're agreeing with each other, but I just think we need to be very careful about what works and what does not work, so that patients aren't sent for some treatment which actually in future isn't found not to be of benefit, just as a time holding thing to keep them away for a while. That would be my view on it.
very briefly, Steve, you want to come back on that, and then we'll move on.
Yes. Well, first of all, I totally agree that context, that's what you're basically referring to, the context of a nice doctor talking to, the therapist taking time for you and all that stuff is very, very important. It accounts for 60 to 70% of a good outcome. Same, by the way, accounts for surgery. If you are a bully with your patient, you're going to get a worse outcome in the end, even if the operation was all right. So that's also proven, and it's also about experience measurements and how everything went on the OR and all that stuff. So the context is hugely important. I totally agree with that. But to come back to the specifics of the conservative treatment, we are now actually doing right now a very large and multi-centered prospective cohort study into and randomized into yes splint, no splint, hand therapy yes, and hand therapy no. So hopefully we get some answers there, but then you cannot sort of evade, how do we say that, exclude the fact that context is very important. But that's the whole being a doctor. I mean, come on.
I agree entirely. I mean, the interesting study would be, and neither you or I could do it, would be nice surgeon versus nasty surgeon.
That's right. Oh, you'll be the nasty one, I'll be the nice one, or the other way around?
We'd randomize, Stephen.
Let's bring Gill in before we go. There's quite a lot of questions coming in from outside. So Gill, do you have any brief comments to make?
Yeah, I think both of them could be nasty if they wished to. I think it's, I'm not an expert in this any more than anybody else is here, but I think it's very interesting that we don't know what causes the pain. It's very interesting that both papers today have suggested that maybe psychiatry or psychological help may be more useful than surgery. So maybe we're doing ourselves out of a job here. I mean, why does steroid injection or surgery work if we don't even know what causes the pain in the first place? And I liked this paper probably because it largely confirmed my own practice, and I will give steroid injections recurrently if the other option is to destroy a joint. Trapeziectomy is an illogical operation, and yet it seems to work to some extent. Joint replacement seems more logical, but we haven't really sure what the long-term outcome on that is yet. We know that they're going to wear out. And the default option is trapeziectomy. And the problem is trapeziectomy works so well. So in my thought is what the bigger problem is when trapeziectomy doesn't work. I'd like to ask Tim two questions. One's on conservative management, which is if steroid is no better than placebo, should we be giving it at all in a cash-strapped evidence-based practice? And then in terms of surgery, I know you say about you do trapeziectomy, but you also admit that you do LRTIs. How do you decide who to do an LRTI on? Would you consider Denovation as an alternative? And if it was Andreea, that young, enthusiastic female surgeon there that had this problem, how would you treat her?
Well, the first one is, I don't know how steroid works, and it may be purely placebo, but for some people it does work. And to be honest, does it matter that much how an injection works? Because the risk of making you worse is very low. I'm quite prepared to agree that other substances may be just as good. And maybe I shouldn't be using steroid, but it's only about £3 a vial. So that would be my justification. When do I do a trapeziectomy with an LRTI? Well, it always bothers me that somebody somewhere, that I will do a trapeziectomy in a young person, which I do, and have a bad result. And someone somewhere will say it's negligent. And I don't want to have to spend time fighting that off. And though I don't believe you need to do it, and the second RCT I did with Alistair Pace, the second one had quite a few young active men and women in it, and it didn't seem to make a difference. But in them, I'll do an LRTI, basically to fight off, reduce the risk of being having to defend a negligence claim, which I'm pretty sure I could. But if you've ever had to defend a negligence claim, even if it goes nowhere, it's still quite time-consuming initially. And so that's why I do it mainly there. But there is always a bit of a thought: what if I'm wrong?
Okay, thank you. Thanks for that, Tim and Gill. Let's go to some of the comments that are coming in, and we've had quite a few, unsurprisingly. We've had questions, and we'll come to them if the panel want to answer them. People are asking opinions from the panel. I suspect I may know the answer to these questions, but they're asking the panel about the role of lipo filling, about the role of PRP. Matt Gardner makes some comments regarding UK hand registry, which is there and it's ready and waiting for the implant arthroplasty cases, but as only very few number of cases have been added. There was a question from Dave Cloak regarding does Prof. Davies see any disadvantages to using a sling suspension technique as a routine in trapeziectomy? I think you've kind of answered that you don't see, from what you're saying to me, you're saying you don't see any benefit whatsoever of using the sling except to reduce the number of litigation cases, is what you've said.
In the generality of cases, yes, that is my view, but there is always a lingering wonder what if I'm wrong?
Yeah.
I don't mind admitting that.
Apologies for my pronunciation, but Hewell Daffyd concurs about pain being a psychological experience and agrees with the panel there. We've got comments from Graham Chung regarding the early results of RP versus trapeziectomy. I imagine he's saying that the early results of implants are good and better than trapeziectomy, and therefore, and the revision of the implant is a trapeziectomy. So would you see any harm other than finance and inconvenience to the patient for doing the implant? I'll ask you that, Prof. Davies.
Well, you say it's better at 6 weeks, but I mean, how have you compared the two? And you may well be right, but the question is, what you're wanting is a long-term result which the patient finds most satisfactory. And to a surgeon, revising an implant to a trapeziectomy may not be a big thing, but have you asked the patient, is that something they really want to go through? And is the benefit, if there is a benefit of a trapeziectomy in terms of an implant in the short term, is it so good that it justifies the later inconvenience of having to have a revision, should that be the case? So, I mean, so many of these questions need to be answered by patients rather than surgeons. And at the moment, the patients aren't really being asked these questions, such as, is it worth 5 years of 5% extra function if you're going to have a revision at 8 years? And I don't know the answer to what patients will think. Some will have different views on it.
Yeah, so I think with the implants, Prof, we're seeing that for the patients who are high demand in their late 40s, early 50s, late 50s, the surgeon is faced with a tricky decision, really, in terms of jumping to a trapeziectomy and sling procedure and having the confidence that will last the course. And so the implant is becoming a default option there. I mean, how do you deal? In fact, that leads us back to not that Andreea is in her late 40s. I'm sure she's not. But where are we going with what is your advice for patients who are young, who have tried all conservative, yeah, and you've said you just do a sling procedure, and have you seen the results of that in terms of?
Well, in young people, it used to be a fusion used to be the solution, and I've given up on that because I don't see, and I haven't done this scientifically at all, but I didn't really see any benefit over a trapeziectomy, and to avoid my negligence, LRTI in those cases. And I haven't seen patients with trapeziectomy and an LRTI coming back, or with trapeziectomy coming back with basically failure with recurrent pain. If it works in the short term, it works in the long term. I've seen about 3-4 patients, I think, over the last 30 years coming back 25 years-ish, 20 years-ish with recurrent pain after trapeziectomy. I haven't seen any coming back after trapeziectomy with LRTI, but that's probably because Nicholas Barton was my predecessor and he never did trapeziectomy and LRTI. And I don't knowingly know anybody who was randomized in either of my studies coming back with recurrent pain due to, I think it's usually arthritis between the base of the thumb metacarpal and the scaphoid having developed in late onset, very late onset. So I think trapeziectomy as LRTI is a reasonable thing to do. And surely the high demand patient is the one for which the implant is most likely to fail.
Okay, but would you say that the theoretical advantage of having an implant in there to prevent thumb subsidence, that makes sense to you?
Well, what does thumb subsidence, is that something that's something we measure on an X-ray? Does it correlate with function or recurrent pain? Tell me. We haven't been able to find any difference. We looked at that quite carefully, looking at, and I'm sure that many of these, as trapeziectomy certainly, they will form a pseudarthrosis with the scaphoid, and when you pinch, there won't be a preserved space there. But I don't think that seems to matter. I don't X-ray them in the long term anyway to find out now, because the patient should come back if they're in intolerable pain, or else they go to Derby nearby to be rescued from me. I don't know. Okay,
so shall we go? Can I suggest to the panel? We've got a number of treatments that the audience would like opinions on, such as PRP, lipo filling, denovation, metacarpal osteotomy, all, let's say, for young patients where we're trying to avoid the trap or the trapeziectomy. Can people share, the panel share their experience on this, and give any thoughts? Because some of them, I suppose you're not burning any bridges, potentially. Tim?
Sorry, I was looking at a question which somebody had written up, so I didn't listen to the question, so you can flog me later or ask somebody else.
Okay, Steve, do you want to give your opinion on that? You're on mute. Yeah.
I know a long time ago, people came to me and asked me if I could do a trial on lipofilling, because I used to do it in the Dupuytren's disease. I haven't got experience with it, but possibly it will. I don't have a good opinion on that. It might work, but I'm not sure. Same as probably the corticosteroids. So I mean, it's really filling that space a little bit. I'm not sure. And I know that Tyson Cobb in the US does a lot of arthroscopic sort of how you call it, with a burr goes a little bit around and makes a little sort of, not even a hemi, but less than a hemi trapeziectomy, and is very fond of it, and he does on doing it. I'm a bit biased because I get a lot of second opinions and see hemi trapeziectomy do not work. So I'm not sure if I could say anything about it. I know René Feitz has done quite a few, I don't know how much, but he's done quite a few osteotomies in young persons, and he's quite happy about it. So I would acknowledge, I think Hywel David, who says something about it, and in his questions. So yes, it is possible to do it. I've never done it myself. I was always scared to do it. And I was, as Tim, raised with CMC arthrodesis in young people for their force. We did it. That was in those days. I'm talking about the 90s, early 90s. We did a retrospective study on the LRTI, and compared to the, actually was the angioplasty, compared to the arthrodesis in all age groups. And we saw there was much more complications in the arthrodesis. That's when I left the arthrodesis for young patients, and then rather do a hemi or a total and do something in between. So I'm not the guy you should ask about PRP. I know people who do a lot with PRP for wound healing. And lipofilling, it could be because the lipo cells have a wound healing effect of the stem cells in the adipose derived stem cells have a have a wound healing effect, so it might be possible, I'm not sure, but they won't resurface your cartilage. And that's probably, well, that's supposed to be the basis of the osteoarthritis. So that's my answer to the question you made.
Tim?
I have no experience of either, certainly not lipofilling. No.
Okay, has anyone done denovation?
Well, is a trapeziectomy partly a denovation? People have done denovations and reported satisfactory results in the literature, but I have no experience on it. But I would have thought the joint continues to feel stiff, whereas most trapeziectomies, I think one of the benefits of it that you get rid of that feeling of stiffness. But maybe with a trapeziectomy, though the joint is still stiff, you don't feel it. With a denovation, if the joint is stiff, you don't notice it.
I think you can get some nice results with denovation. How long it lasts, I'm not sure about. I'm too young to know. But I think if you've got a crunching, grinding feeling, that obviously doesn't go away. But the ones where it's pain and they are still quite mobile, I think they can do quite nicely for at least a while with a procedure which really gives them very little downtime. So I don't think there's many negatives to it, as long as they accept that it may not work for them and they may need a bigger procedure. But it might do, and it might do for a period of time. And I think metacarpal osteotomy, again, in highly selected people is probably a very good option. But again, it's patient selection. And it's not a lot of the older ones that we see with a really bad grade 4 osteoarthritis.
Okay, speaking of grade 4 osteoarthritis, is there a preference for when we have CMCJ and STT arthritis? Tim, I imagine you'd go for the trapeziectomy?
I'd just do a trapeziectomy and it just seems to get rid of, I mean, there's always this worry, are you going to get pain still from the scaphoid, trapezoid joint? But I think I could think of one or two people I've regretted it on, but I still, as a primary procedure, just do a trapeziectomy.
Stephen?
I would, if I have an evidence of the scaphoid trapezoid joint osteoarthritis, and I always look for it in every trapeziectomy, but and if that's already beforehand, then I would take out the proximal part of the trapezoid.
That's not as easy to do as it may sound in my experience.
I totally agree, and I check it all the time under the bucky, or whatever you want to call it. I don't know how you call it in proper English, actually.
Okay, fantastic. Thank you to everybody on the panel tonight. We're just about out of time. We've had quite a significant number of questions. I think we've managed to stimulate some discussion and thoughts about dogmas. I'm just going to ask Lam, just to come back in for final thoughts. Really, is this what you were hoping for in terms of the issue that you edited, and final thoughts for those authors out there who are considering writing papers, and what is your advice there?
Well, I think this is as I said earlier, this is a special issue, and the people who are invited to write this are people that they expect that they will be challenged. I think the title that team had for the approach, I think we went back and forth a few times, and because initially I asked him to write something on dogma, and I realized that eventually we are not challenging one dogma. We are finding out there are so many dogmas, but what are the dogmas? And I want the team to tell us what these dogmas are. So his paper is a personal approach or a personal opinion of what the dogmas are, and I think he presented a very balanced article. So I'm delighted with that, and what I really hope is that after tonight's journal class, more people will read that special issue, and more people will be challenged to think critically. And if the special issue or each article raise more questions than answers, then I think it serves its purpose. Thank you.
Thank you. Thank you to our authors who, first of all, undertook this work and then were brave enough to come along and be challenged live. Special thanks to, of course, to Marybeth Ezaki, who's currently in Colorado, where I believe it's pretty cold and she's obviously in a completely different time zone. We really appreciate that she's made time for us over here in Europe to join us and to give us her time. Thanks also to Stephen Hovius from Rotterdam for coming and joining us, and to Tim Davis and Gill Smith, and of course to our presenters, Andreea and Inga. Brilliant job, and it's an appeal really to all junior trainees and upcoming hand surgeons. If you'd like to be part of this journal club, then please get in touch, and we can perhaps select you to come on to the show and present onto the meeting and present some papers for us as part of this journal club. The aim of the journal club is to continue to roll on every 2 months, and it's truly a pan-European journal club. So fellows from all around Europe can can participate. We're getting a lot of positive comments in the chat box to all the panel members for tonight's meeting. The next meeting, just to confirm, will be in 2 months' time, is going to be on May the 26th. So the social media and the emails will go out across Europe again for that. And you will get an invitation to register for May afterwards. The other thing is that these meetings are awarded CME points, and if you get in touch with the office, we can then sort that out. Lots of congratulations coming in from around the world for hand surgeons from around the world, in fact, are writing in for tonight's meeting. So thank you again to everybody. Thank you to all of you at home. There's currently 111 participants on the call, and we hope to continue to grow this journal club. And this is probably one of the positive things that have come out of the lockdown, that we have a truly fantastic opportunity to discuss articles in this format and this forum. It certainly beats the traditional journal clubs, where as the size of the firm has been dwindling and we've not been able to get hold of a good time for juniors and consultants to get together. And the fantastic thing here is that we've obviously got the authors and the editor, as well as our presenters. So that's good evening from me, and we hope to see you in 2 months' time for the next edition of the Journal Club. Thank you very much.